Good evening and welcome to the Henry Ford Neuroscience Institute lecture series. We're happy to welcome Dr. Jason Schwab, who is the Surgical Director of the Movement Disorders and Comprehensive Epilepsy Centers, to give a speech about appropriate treatment of localization-related epilepsy. Before we begin, I just have a few announcements I'd like to make. If you click on the, if you're on henryford.com NeuroTalk, and you click on full screen, to your left, you will be able to click on a logo, a little emblem on the upper left hand of the screen, and a chat screen will come up on the right side of your screen. Please submit your questions that way, and then we will make sure that Dr. Schwab gets them and he's able to answer them after the end of his presentation. If you're listening to us via phone, we will ask you to please put your phone on mute until after the presentation is over, and then afterwards we will take questions via the phone. Thank you very much, and without further ado, I'm going to hand it over to Dr. Schwab.
Great. So I'd like to thank the Epilepsy Foundation of Michigan for working with us on setting this up, and very excited to try a web-based medium so that people can see some of the things we're talking about and get a visual idea as opposed to the normal phone conference. Just for the sake of time, we're going to reserve questions for the end, but we have an hour and a half, and I think my talk will take about 40 minutes, and then there will be more than adequate time for questions. The standard way in that we do these things now is we have disclosures at the beginning of all our talks. So my disclosures are that I have NIH support for research on imaging in epilepsy, and I was also an investigator on the pivotal trial for the NeuroPace RNS system, which is completed and has now been FDA approved for the past 2 years, and I'll talk a little bit about that later. So, I think one of my biggest take-home messages for people, and one of the things that we really need to convey to the public is just how bad epilepsy is. And obviously, people suffering with epilepsy realize this as well, but sometimes people don't have quite a good idea of the long-term consequences of having epilepsy. And the reality is that people with epilepsy have decreased life expectancy, about 10 years off your life if you have epilepsy from a known cause like mesial temporal sclerosis, and 2 years lost life for people with epilepsy of an unknown cause. People with epilepsy are 5 times less likely to hold a job. They're about 5 times more likely to commit suicide, and about 20% of newly diagnosed people with epilepsy feel stigmatized. And one of the big problems is that people have a seizure, they're not able to protect themselves, and they fall or they have an accident. And the risk of accidental death in people with epilepsy is quite high. It's about twice that of the general population. And of people with epilepsy, about 6 to 20% of people die from some sort of trauma. That's separate from this thing called SUDEP that many of you may have heard of. That's an acronym for sudden unexplained death in epilepsy. And SUDEP does not include people who have prolonged seizures or have a seizure and drown or have a seizure and get into a car accident. These are people who just drop dead or they don't wake up. And for people out in the community who have just been diagnosed with epilepsy, the rate is low. It's about 0.01% risk of dying of SUDEP per year. But if you've gone to the point that your epilepsy is severe enough that you're referred for epilepsy surgery, the rate is as high as 1% per year. Now that's the rate of SUDEP. If you combine the rate of SUDEP with the rate of death from trauma or drowning or other causes of death associated with epilepsy, we're talking about a 15% chance of dying from your epilepsy each decade. That's really high. That's higher than a lot of cancers. And we actually, for some patients, have very successful treatment. This can be reduced to that of the general population if the person has a type of epilepsy called temporal lobe epilepsy, and our success rate in eliminating seizures in that disease is about 60%. If you compare that to one specific type of breast cancer with node negative and no metastases, our treatments with chemotherapy reduce the risk of death by 10%. And so, we would never tolerate not offering a chemotherapy to a woman with breast cancer for a 10% improvement in mortality over a decade. And it's really unclear why we would accept not offering surgery to a person with epilepsy with the same absolute benefit. So who's at risk of SUDEP, or who's at risk of doing poorly? And at what point should you consider being referred to a center that has a lot of experience in evaluating patients for potential surgery as a cure? These are actually very well mapped out at this point, both from Institute of Medicine, from the American Academy of Neurology, and from the National Association of Epilepsy Centers. And seizure control is defined as having no seizures with altered consciousness over the past year. And if you're not sure if you've had altered consciousness during your seizure, if you don't remember it, it's likely that you have altered consciousness and poor seizure control. And the Institute of Medicine suggests that, or recommends that, clinical practice guidelines and recommendations from professional organizations suggest that when the diagnosis is in question, or seizure control is not achieved after an adequate trial of 2 or 3 appropriate seizure medications, or 1 year of care with a general neurologist, patients should be referred to an epileptologist or an epilepsy center. So an epileptologist is a neurologist specializing in epilepsy. And the National Association of Epilepsy Centers recommends referral to an epilepsy center if seizures are not controlled after treatment for 1 year, seizures continue after trying 2 or more medicines, or the patient has bothersome side effects from those medicines. The person wants to learn about non-medicine ways of treating seizures, like ketogenic diet. The person has concern about how epilepsy affects his or her daily life, or if the person is pregnant or wants to become pregnant. So again, under control means 0 seizures with altered level of consciousness. In this important study, where you see the table from 2000 that was published in the New England Journal, shows that essentially you can treat epilepsy successfully with 1 or 2 medications about 2/3 of the time. However, if you've already failed 2 adequate trials of medications, your likelihood of coming under control with a new medication or a new additional combination of medications is only 1 to 3%. It's very low. It's very unlikely. And really remarkably, in spite of significant numbers of medications that have been approved since this paper came out 16 years ago, this number really hasn't changed. So if you've failed 2 drugs, you're really not going to succeed cycling additional drugs. And during the time that you're cycling additional drugs, you're actually at risk of accidental death from your epilepsy or SUDEP from your epilepsy. So for those on the phone, the next slide shows a figure of sort of some of the different surgical options, at least for temporal lobe epilepsy. And we can tailor that, and the idea is to take out the part of the brain that's causing the seizures, not take out parts of the brain that are not involved in seizures, and not take out parts of the brain that might hurt the patient. And the resection can be tailored. The traditional way of doing this is with an incision and taking off a piece of bone out of the skull, and then taking out that piece of brain and then putting the skull back on. The surgery takes about 4 to 6 hours. Patients usually in the hospital for about 3 days. So there's actually a trial done that was published in 2001 in the New England Journal by the group in London, Ontario, where they randomized patients to either temporal lobectomy or continued medical therapy. And the way they were able to do this was because they had a waiting list for surgery. They had only so many surgeons in Ontario able to do this type of surgery, and so they were able to compare these groups. And the patients who underwent surgery did really well. About 58% were seizure-free. Maybe not, they might have some small, simple seizures, but no seizures that were causing impairment of consciousness. Whereas the likelihood of being free of seizures that impair consciousness in the medical group was 8%, and this is in the care of really very good expert epilepsy neurologists. And if you look at the percentage without any seizures, the rates are about 38% in the surgical group and 3% in the medical group. And surgery is also quite significantly better than continued ineffective medical therapy in terms of quality of life in these patients as well. And they did this quality of life and epilepsy inventory and followed these patients, and the surgical group did quite better, as those of you who can see the slide can see. What I find really interesting in this is, understandably, patients are very scared of the risks of surgery. It's a big step to go through brain surgery, but the risks were actually higher in the patients who continued on the wait list with continued ineffective medical management. So the only death in this trial was in the medical management group. It was a patient who died of SUDEP. And if you look at depression, the rates were pretty similar. There was a risk of wound infection in the surgical group that was one patient out of 40. And obviously, the medical management group didn't have that risk because they didn't have surgery. About 2 patients out of the 40 had a decline in their verbal memory that interfered with their ability to work. And a lot of patients, based on the way the surgery was done, ended up with a visual field cut out of the corner of their eyes opposite to the side that was done. That's called a pie in the sky deficit. And if you look at this systematic review done by Jerry Engel out of UCLA in 2003, looking at the literature about the risks of surgery, the risk of death is less than 1%, and the risk of serious permanent neurologic deficit, like a stroke, is about 3%. So it's quite low and much, much less than the risk of death from uncontrolled seizures. So as a result of this paper and a bunch of other papers, the group at Columbia University in New York did this decision analysis where they looked at different patients. And the way you do this is you take a patient and you say, okay, well, if you're this age and you go forward with surgery, and this is the rate of complications, this is the rate of death from surgery, this is the rate of not being able to work, what are your chances of having a good outcome versus a bad outcome? And they do the same for patients who are in the medical group, and they run these simulations multiple times with a prospective range of ideas as to what the rates are based on the literature. And in this analysis, what you can see is that patients who, if you're a 25-year-old and you choose surgery, even with the attendant risks of surgery, you're going to live 5 years longer than a patient who chooses medical therapy. And when you adjust that, not just length of life, but what about a quality-adjusted life expectancy? Because your quality of life is ostensibly better if you don't have seizures and don't have any deficits than if you continue to have seizures, which is also is also better than if you don't have seizures but have deficits. And when you do the calculations, a 25-year-old is going to gain about 8 quality-adjusted life years by this analysis. And the benefits are still pretty impressive, even if you're talking about a 65-year-old in terms of increased length of life and quality-adjusted life. There have been other studies, like this study out of the group at Queen Square in London, that show that the results are not just good for a year or two. The results continue to be quite good at 10 years. And their group here, for those who can see the screen, for patients who underwent an anterior temporal lobectomy more than 10 years out, they still have a 50% rate of patients being seizure-free, at least seizure-free of seizures that alter level of consciousness. So I hope that I've convinced you or given you some information that surgery is better than continued ineffective medical therapy. But this is not just a problem here in Michigan. This is a problem nationwide. And the Institute of Medicine published a monograph in 2012 that suggested that about 100 to 200,000 patients a year are surgical candidates. But we know from other data sources that there are only about 4,000 surgeries done. So, we are reaching a very, very small percentage of patients who might benefit in a very real way, not just in terms of life expectancy, but quality-adjusted life expectancy. I think a lot of that is due to fear of surgery. As a result of these data, and also from a practice parameter from the American Academy of Neurology in 2003, there have been recommendations to neurologists that they are supposed to tell patients about these data if they have epilepsy. And yet, a lot of patients referred to epilepsy centers like ours have had epilepsy on average for 22 years, and most of them on average are being seen more than 10 years after they've become refractory, after they've failed 2 medications for their seizures. And for those of you who can see the screen, if you look at this scatter plot on the right, the longer you've had epilepsy, the more damaged the brain has been, and actually the less likely surgery is to benefit you. So people do better if they have surgery earlier. So why are patients not referred to experienced surgical centers? So I think some of it is initial benign appearance. Some of it is a knowledge gap. I think many of us, we see a patient and we start a medication, and we see the patient's seizures go down by 50%. I had a recent patient that we put a vagus nerve stimulator in. Her seizures went down 70%, and they were much less severe. And we looked great, and she was really happy, but she still had consciousness-altering seizures, so we really hadn't made a big difference in her ability to have a job. We hadn't reduced her risk of dying from her epilepsy. We'd made things a little bit better for her quality of life, but not as much as we could if she turned out to be a good candidate for a surgical resection. And I think that a lot of patients out there, they see a good neurologist who gets their seizure frequency down, and they see it as a success, whereas the real goal is to be seizure-free. But the other problem is that human beings are really bad at assessing risk. It's sometimes hard to get in to see us. There aren't that many surgical centers with our level of expertise, and there's an understandable fear of surgery. For any of you who are interested, I've been reading this book for the past several months. I've made about 200 pages in. This book by Daniel Kahneman, Thinking Fast and Slow, which really looks at how bad we are at assessing risk as human beings, and we're all guilty of this. So one of the things that he talks about is something called loss aversion bias, and you can do psychological experiments with people and with gambling paradigms, and people will do a lot to avoid losing $1. Even if they continue playing the odds, they're going to end up getting a $2 gain. So people are very bad at betting, as most casino owners know. And there's also something called status quo bias, which basically means that you get used to what you're used to, even if it stinks. And doctors, patients, and parents get really used to terrible epilepsy. One example of this that Orrin Davinsky, who's an epileptologist at New York University, brought up at a national meeting a couple of years ago was what happened after September 11th in 2001. And with the 4 airplanes that were hijacked, 3,000 Americans died, but there were actually more Americans killed as a result of that terrorist attack, and a lot of that was because Americans drove more and flew airplanes less. And we were all worried about another terrorist attack happening in an airplane, and we feel like we have control when we're behind the wheel, but the odds are not really in our favor. And so the calculation is that about 1,600 Americans died, more Americans died than usual between September 11th, 2001 and 2002 due to excess motor vehicle accidents. So even if there were one hijacked plane per month going down, your risk as a traveler in the American skies would be 1 in 540,000 per year of dying in a terrorist attack. That's one hijacked plane a month, and obviously it's never been that frequent. But your risk of dying in a motor vehicle accident as an average American is 1 in 7,000. So a couple of orders of magnitude worse. So how do we improve the story state of affairs? Well, we give talks like this, and we try and educate clinicians and patients, but it's really also incumbent upon us to understand patient preferences. And my partner, Ellen Ayer, is trying to do some work with the Epilepsy Foundation to do focus groups, and we'll probably be contacting a lot of you to really understand why patients choose things the way they do. It's also incumbent upon us to figure out much better who's going to benefit from surgery and who isn't. And the other thing that we've worked very hard at Henry Ford and at several other centers around the country is using improved technology to make it less scary and to really reduce the risks. Now, one other reason to see an epilepsy specialist is due to this thing called psychogenic non-epileptic spells, or PNES. And the rate of this is actually much higher than one would expect. And about 10 to 40% of patients referred for video EEG monitoring or phase 1 monitoring are found to actually not have epilepsy. And a lot of them have not had epilepsy for 5 to 10 years. And have been on medications that make them dopey, that cause side effects. Because of their spells, they've lost their job. We've even seen a number of patients, and we're not the only center that has seen patients who've come in with vagus nerve stimulators implanted for epilepsy and then found that the patient doesn't actually have the disease. And there is some evidence that patients diagnosed early with PNES do better. They tend to get better resolution of their spells and have less disability. So that's yet another reason to go through video EEG, where the patient is admitted to the hospital, hooked up to an EEG monitor, and there's a video camera running, and they're basically as an inpatient for several days as their medications get tapered off, and we try and observe them having a seizure. So, goals of surgery. The goal of surgery is to remove a part of the brain that's either causing seizures or is an essential part of the circuit involved with causing seizures. And the goal is seizure freedom. Now, we can't always get everyone seizure-free. About 30% of patients can be completely off their medications if they have temporal lobe epilepsy. But again, 60 to 80%, you can get them free of seizures that affect their level of consciousness, but they might have to continue on their medications. And then, of course, do no harm. So the evaluation process is long and arduous and contains a number of steps. The basics of evaluation for patients to see if they're a surgical candidate is phase 1, as I described. The patient's admitted to the hospital to record seizures with videotaping and EEG. We often decrease or stop the seizure medications to try and get the patient to have a seizure, so we can see it. It's the only time patients come into the hospital and we try and make them sick. It also consists of getting an MRI to look if there are any abnormalities in the brain, and also neuropsychological testing, which is generally about 3 to 5 hours of doing puzzles that can tell us where there are discrete problems with different functions of the brain. And then if things aren't clear, there are additional things we sometimes do to better assess where the seizures are coming from, if they're coming from a discrete place, and what the risks are of surgery. And that can include something called Wada, PET, SPECT, and Magnetoencephalography. And I'll talk about those in a minute. So for neuropsychological testing, if the person has a deficit in a certain function of the brain, let's say doing verbal puzzles or visual puzzles, or naming as many animals that start with the letter F in 30 seconds, that can sometimes point us to a discrete area in the brain that's not working well, and can tell us, number one, where a seizure is coming from, and number two, if we take that area out, are we going to hurt the person? We also use neuropsychological testing to identify psychiatric and social issues that the neurologists and neurosurgeons might not have picked up on. This other thing called a Wada test is similar to neuropsych in that you're trying to figure out, are there discrete areas of the brain that aren't working well? And what we do in this is actually a cerebral angiogram. The radiologist puts a catheter in the patient's artery in the groin and snakes that up into the blood vessels going to the brain, and can selectively put different parts of the brain to sleep. And we can do that to localize speech. We can do that to determine whether there's a significant problem with memory in one particular area of the brain, or if other areas of the brain can pick up the slack. And really, for patients with mesial temporal lobe epilepsy involving a part of the brain called the hippocampus, it helps us determine whether the hippocampus that is not going to be resected can support the patient's memory. There's also something called positron emission tomography, or PET, and this radioactive sugar is given to the patient. And in many patients, if they have had a seizure a while ago and aren't seizing right now, the area of the brain that had the seizure is often showing decreased metabolism of sugar because it's sort of recovering from that excessive workout of generating a seizure. And sometimes that can help us figure out where seizures are coming from if it's not obvious on the MR. And then there's this thing called magnetoencephalography. For those of you who can see the picture on the left, it's putting a large receiving coil with magnets around the patient's head, and not just looking at electrical signals like an EEG, but looking at magnetic fields. And that can sometimes help us figure out where seizures are coming from too. And our group at Henry Ford has been a leader in this field for decades. We are one of 28 centers in the United States and the only one in Michigan who have this technology. Now, some patients are really straightforward. There's a clear abnormality on the MRI, as you can see here. This area where the arrow is a little smaller. It's also a little brighter on this other type of imaging called flare. Sometimes the patients have symptoms that really point to one side or the other. So sometimes patients with temporal lobe epilepsy have something called a figure of four, where you watch them on the video and they extend one arm and flex the other one. And that if the patient extends their right arm, that suggests that the seizures are coming from the left temporal lobe. The video EEG fits, and sometimes the neuropsych testing fits. And that's really all you have to do. If everything fits and points to one temporal lobe, you can go and resect that with very great success. The problem is that many patients are not, and of patients that we see, I think it's probably more than 20% are really not straightforward, and you have to do other tests to try and figure out where their seizures are coming from. It's not clear, is it coming from the right temporal lobe or the left, or is that coming from another part of the brain other than the temporal lobe? And when we're confronted with that, we're still pretty aggressive in trying to figure out where the seizures are coming from, because we still might be able to cure the person. And so the way we deal with that is if we can develop a hypothesis that is coming from one of 3 or 4 different areas, we can put electrodes directly on the surface of the brain. And that way you eliminate artifact from the skull and trying to record electrical signals from through the muscle. And you can put these electrodes directly on the brain via a bone flap. The patient goes to the epilepsy monitoring unit for anywhere between 3 days and 3 or 4 weeks to try and figure out where their seizures are coming from. This is nothing new. We've been doing this as a field since the late 30s. But it's not a great operation. When I was a resident, I was told that anterior temporal lobectomy was the most beautiful operation in neurosurgery, and this was one of the worst. It's really expensive. The risks are not insignificant. There's a risk of infection that's about 2% to 5%. There's a risk of bleeding in the brain that's about 4%. There's a risk of increased pressure in the head that's about 2 or 3%. So when you add up the rates, you're really looking at about a 10% risk, and the complication rate can be even higher if you're leaving the electrodes in for a long time, or you really have to use a lot of electrodes to try and figure out where things are coming from. So we've, and a few other centers in the country, have worked at really trying to reduce these risks with what's actually not a very new technique called stereotactic EEG. And instead of doing a big opening in the skull and putting big grids on the surface of the brain, we can place multiple tiny little depth electrodes that have a diameter of less than 1 millimeter within the brain surface through tiny little twist drill holes. And the complication rate is very low. We haven't had any infection rates in the 10 or 20 we've done here at Henry Ford. The risk of hemorrhage is quite low. The largest series out of Europe in Bonn showed a 6% risk of serious complication, which is much better than with grids and strips. And in a recent report from the Cleveland Clinic, the risk of hemorrhage without any symptoms was about 2%. In many patients, is actually a lot better than grids and strips because you can sample deep structures more easily. And instead of a two-dimensional recording, you get a three-dimensional recording from a significant amount of tissue. There are still circumstances in which grids and strips are appropriate, really, for trying to figure out where speech areas are in the brain. But for most things, we've really moved towards this technology, as have a lot of other centers in the U.S. So as I said, this is something that is not that new outside the U.S. and Europe. They've been doing this for quite some time. It was first reported in the mid-'70s. But with what's really changed and made this more feasible in the U.S. Is robotics and improved imaging and the ability to merge MRI and angiography and other things to make sure you avoid blood vessels as you put these electrodes into the head. So we're actually the third center in the U.S. To do robotic placement of these types of electrodes. And the way we used to do this with something called a stereotactic frame, where you had to reset the trajectory for each electrode you put in, would take a very long time. And at this point, I can put in each electrode in about 10 minutes once we get started. So we're able to reduce an 8-hour surgery to an hour and a half. And the patients are much more comfortable after surgery. They don't have the soreness of having a large bone flap taken to put in a large grid or strip. And we get beautiful recordings, and they go to the EMU pretty happy the next day. And this is one of my partners, Ellen Ayers' patients, and you can see for those of you on the webinar that really can put in a large number of electrodes and sample a large amount of the brain that we really couldn't have before without significant risks. So that's one way we've tried to make this easier on patients and less scary. One of the other things we've worked on the past 2 or 3 years is doing minimally invasive ablation of this tissue. So instead of doing a large bone flap and cutting the chewing muscles at the side of the head to get to the bone, we can actually implant a laser probe right into the area that we want to, that the seizures are coming from most of the time. And what's really changed things and made this technology possible is we're able to implant a probe, bring the patient into the MRI, and there are these new sequences on MRI where you can measure the temperature of different areas of the brain in real time. So we can turn on the laser and make sure while we're monitoring with the MRI that it's not getting too hot, and it's not getting too hot in places we don't want it to get hot that might hurt the patient. And yet make sure that we're able to generate a lesion that's going to do the trick. And we've done a few of these, and our seizure-free rate in the 4 we've done is about 50%. And theoretically, because you're not going through as much tissue to get to the target, this should lead to decreased risk of that pie-in-the-sky visual field cut or neuropsychological deficits, and I think it'll reduce the fear of surgery too. The patients we've done have all gone home the day after surgery, and even that, we probably didn't even have to keep them that long. And they just have a 3 millimeter incision. So this is an image of the modeling done by the computer in the middle, and then we gave contrast at the end of the case, and it corresponded quite well with the monitoring. And this is a year later, and you can see just the asymmetry between the right and the left side. The right side, you can see there's something that's not on the left side, and that's where we've done the lesion, and yet the rest of the brain looks really normal. So the advantages of lit or laser interstitial thermal therapy, theoretically it should lead to decreased risk of stroke and visual field cuts. We've seen decreased length of stay and decreased discomfort and faster recovery. And one of the nice things about this is that if it doesn't work and the seizures are coming from a nearby part of the brain, you can go back and do a standard anterior temporal lobectomy later if it fails. And the group at Emory published a couple papers last year that showed that there's a significant decreased risk in neuropsychological problems when compared to their prior history of doing anterior temporal lobectomies, and the surgeons there are very experienced. And so they didn't see patients, their patients who underwent lit had decreased problems compared to anterior temporal lobectomy in naming names and famous faces if it was done on the dominant hemisphere, recognizing famous faces in non-dominant hemisphere, and they had some preliminary evidence that they didn't report on delayed recall. And there are some patients, one of the patients I've operated on had temporal lobe epilepsy on her dominant hemisphere and really normal verbal memory. And so in patients like that, the risk of doing an anterior temporal lobectomy and really affecting their thinking and their speech is about 20%, and most surgeons actually wouldn't even offer resection to a patient like this. And we were able to offer her laser interstitial thermal therapy, and with that and with a couple of adjustments to her medications after surgery, she's now seizure-free and is a couple of years out. The disadvantages is sometimes it's just hard to get a good trajectory where you can avoid blood vessels and get the laser where you want it to go. You're limited, it's not going to work well if it's in other parts of the brain, and you think it's in the amygdala and hippocampus. So it's very important to know exactly where the epileptogenic focus is. If it is somewhere else, that area can be taken out or laser ablated. And actually the cost of the laser is quite expensive. The disposable is quite high. So it's sometimes hard to justify to the hospital. And the other issue is that, this is new, and we don't have 30 years experience in it. So even though it looks really good, we don't have such a good track record as we do with anterior temporal lobectomy, which has really withstood the test of time. For the sake of completeness, we don't really do this here. You can do focused beam radiation on this area of the brain, and the seizure-free rates at 2 years are about 65%, which are quite good. That being said, radiation has delayed effects. It really doesn't reduce the seizure rate until you're almost a year out, during which time the person still is at risk of death and SUDEP. And since many of our seizure patients are quite young, there's a risk that 30 years later they're going to come back with a brain tumor that's been caused with the radiation. But I think this is a potentially useful technique in selected patients. The closest center to Michigan that's involved with this trial is actually Indiana University, and that's just actually where the trial is being run out of now by Dr. Barbaro. So, what do we do if more than one area of the brain is causing seizures, or if removing that area would lead to an unacceptable deficit? And we actually have a few options for this. For patients with something called drop attacks, where they're having seizures and they lose tone and they fall and they get hurt, One way of dealing with this is a procedure called a corpus callosotomy, where you go in and you cut one of the major connections between the two hemispheres, and that can prevent the spread of seizures from one hemisphere to the other. That's not going to cure the patient's epilepsy, but might stop them from hurting themselves when they have a bad seizure and drop. In most patients, it really eliminates drop attacks. Another one that many of you have probably heard about is vagus nerve stimulation. This is an implant that's manufactured by a company called LivaNova. It's been around for a while. It's FDA approved in 1997 for patients with localization partial epilepsy, although a lot of patients have, with generalized epilepsy, have gotten VNS off-label and seem to do quite well. In general, this is not going to make patients seizure-free. It only makes patients seizure-free about 5 to 10% of the time. But in about 50% of patients, they get a greater than 50% seizure reduction. And surprisingly, this seems to get better over time. So results at 1 year are better than at 6 months. Results at 2 years are better than at 1 year. But in general, we reserve this for patients who are really not going to be candidates for resection, that we can't make seizure-free. This is sort of one of the next best things we can do. Another thing we can do if we know where the seizures are coming from, but it's too unsafe to take the area out, if for up to 2 lesions, we can put a device in called the NeuroPace RNS. As I said at the beginning of the talk, we were involved in this pivotal trial where we implanted patients, and then some patients had the device turned on, some didn't. And this is a really interesting system in that there are electrodes going into the brain, and then a small pacemaker/computer. It works more like a defibrillator. So it's reading from the electrodes, and when a seizure or the beginning of a seizure is detected, it delivers a small electrical pulse and aborts the seizure. This does not cure epilepsy, but it can really help quite a bit, and we think it helps a lot more than VNS in appropriately chosen patients. So this was the initial study where it was really only a 3-month period that patients were randomized to no stimulation or some stimulation. And you can see that the seizure count was much better in the patients who got real stimulation. What's been really impressive about this, even though it hasn't made patients seizure-free, is that it seems to get better over time. That may be because the way this works is not just that it detects a seizure and delivers a shock, but that data is downloaded to the company, and the system can be programmed over time to even better detect when a seizure is going to start and deliver that shock earlier. So a lot of patients, when we're looking at several years out, 5 years out, the median seizure reduction is about 60-65%, and our responder rate is which is percentage of patients with greater than 50% seizure reduction, is also about 60%. And these patients have sustained improvements in quality of life. In the trial, these were really patients that everything else had been tried on, VNS and sometimes resection. And what's been really impressive to me, since we're still doing battery changes on these patients, is the patients, once that battery starts to go, they want it replaced. And unlike many other device trials, 97% of the patients implanted in the trial are still using this, and some of these patients are 100 months out, so 8 years. So in conclusion, the messages I'd like people to take home are that uncontrolled epilepsy results in a decreased life expectancy and decreased quality of life. 1 seizure a year is too many. Surgery in the appropriately chosen patient can result in a cure and is safer than continued ineffective therapy. And I think that emerging technologies like NeuroPace and laser ablation and robotic electrode implantation are likely to allow better localization of areas causing epilepsy and make surgery safer. So I'd like to thank you for your time, and it looks like we have plenty of time for questions. This is a big effort. It takes a lot of people. For those of you who can see the photo, this is our group, and actually my partner in crime, Dr. Alan Ayer, who's the other epilepsy surgeon here at Ford, was in the OR and didn't make it in this picture, so I had to put her here as an inset. So thanks. What we're going to do now is I'm going to answer questions via the chat, and then as we go through those, we may open things up to the telephone. So the first question that we have is there an age limit for epilepsy surgery? And I think we used to think that that was a problem as patients got older, but our results that were actually published about 5 years ago, soon after I got here, from a lot of data from my predecessor, Kost Alasevich, showed that older patients can do just as well as young patients in terms of seizure freedom. Again, I showed you that slide that showed that patients who've had seizures for more years are less likely to do as well. But there really is not an age limit for epilepsy surgery as long as the patient is healthy enough to undergo surgery. The next question I have here is how much time would I need to recuperate after surgery? And it depends what we do. So for patients who undergo laser ablation or implantation of a NeuroPace device, they're feeling pretty well. They tend to go home the next day. They're usually home for a couple weeks. And depending on what you do for a living, you can go back to work at about 4 weeks. People cannot drive until they're free of consciousness alternating seizures for 6 months, but patients can recuperate quite well from that. For patients who undergo traditional open surgery, and we still do that for a lot of patients, the recovery is a little bit longer. And we're cutting usually at the side of the head here, and there are muscles here that you use for chewing. So that can be sore. And also a lot of patients complain of fatigue, and that can go on for a few weeks. So usually people go home about 3 or 4 days after surgery. They're usually not returning to work until they're about 6 weeks out. There's also a recovery process if we're doing electrodes, and people need to figure that if we're implanting electrodes to figure out where their seizures are coming from, they could be in the hospital anywhere from a week to 4 weeks just for that. And then depending on what the next step is, whether it's an open resection or visual laser ablation or NeuroPace, you have to factor that time in as well. One of the questions was, will I be awake during surgery? Most of our patients aren't awake. There are some times when the seizures appear to be coming from the areas that are close to areas of the brain important for speech or movement, where we would keep the patient awake for surgery, but that is pretty rare. And frankly, the patients that we do that on, they tend to tolerate it quite well. And then the last question I see here is, can I drive after surgery? And you can drive after you have not had a consciousness-altering seizure for 6 months in the state of Michigan. That may be different in other states. More questions, Jen? Okay, so just a reminder that you can click on the scrolling link on the bottom of your screen to submit questions as well. And since we don't have any more webinar online questions that people are typing in, we're going to open up the phones. That's great. Oh, I think I did something. I pressed the button. So. Oh.
Here's one from Lori, our daughter.
Okay, so we have a question. What tests are needed before surgery? So there are first we need to figure out where their seizures are coming from. The bare minimum is MRI. an inpatient admission for video EEG monitoring and neuropsychological testing. Other tests that would need to be done before surgery are going to be dependent on that. And then there are all the standard blood testing and depending on the person's age, urinalysis and EKG and chest x-ray. Another question is, our daughter has been on multiple high doses of medication and tried ketogenic diet for a year and also has a VNS. She was declined for epilepsy surgery, and what other options does she have? So, I think it depends on why she was declined for epilepsy surgery, and we've seen patients where we see the patient and we agree and we say, epilepsy surgery really isn't an option. If it was done a while ago, NeuroPace, it was only FDA approved in 2014. It might be an option. Similarly, the laser ablation, which has a broad FDA approval for tissue ablation, might be an option, but I think it's hard to know. We have also seen patients where they've been evaluated and the group evaluating that patient was unable to figure out where the seizures were coming from, and we have been able to figure that out through MEG or other technologies that other people don't have. So it's usually worthwhile. Yeah, I think it's hard to, so let me just repeat it for those who couldn't hear. This person who submitted this question says she has multiple focal points from a stroke and brain swelling 11 years ago. I think it's hard for me to say yes or no. There's no way that we can do anything. I think there's often, we see many cases that are told by other centers that there's no hope, and we're able to find some hope, especially with some of these newer technologies. Okay, so we're going to open up the phone, and at the risk of complete chaos, if people have questions. Russ, are you there? He's probably on the webinar. So people can unmute their phones if they have any questions. Okay, now I've figured out how to turn up the volume on the speakerphone, so in case I missed anyone. Okay. So I think we're done. Well, I hope this has been helpful and informative. And if you have any questions, obviously there are great resources through the Epilepsy Foundation of Michigan, or you can contact our group through the Henry Ford website, henryford.com/epilepsy. And that'll have more information as well. Okay, thank you very much.